Thank you, David. So I would like to start by thanking the organizing committee for giving me this opportunity to talk about this topic. I would like to start to telling you that treating separately HER2 advanced gastric cancer patient has been so far the only successful approach for treating specifically with targeted agents these difficult disease. And I'm going to go with you because I think we have to reflect, and perhaps the data we have may are driven us to go to a different place, particularly in the way we design trials. In fact, in this table you may find some other trials concerning anti-angiogenics or anti-EGFR antibodies or even c-Met antibodies showing constantly negative results in this setting. But moreover, and when we started having this data, and it is our standard approach to determine HER2 when we have a patient with advanced gastric cancer, and if amplified, going for a treatment with trastuzumab together with combination chemotherapy. And again, I would like to underline the fact that in a populational approach, patients are gaining. All trastuzumab treated patients did better in response rate, in progression-free survival, and also in overall survival with a hazard ratio of 0.74. However, when we try to treat gastric cancer, we sometimes we try to do the same as with breast cancer. The key point also is that whenever we measure the level of amplification by copy number or by FISH, there is a direct correlation with quantifying amplification and the effect, the survival effect we expect. But things are not like in breast cancer. In fact, when we go to lapatinib, another anti-HER2 targeted agents inhibiting the tyrosine kinase part of the receptor, despite having some effect in activity in first and second line, there is no survival benefit when advanced gastric cancer are treated, HER2 positive are treated with this compound. Moreover, when we analyze the results of a different trial using TDM1, which is a successful approach for HER2 positive patients in breast cancer, the results of these type of studies in second line are not so positive in gastric cancer. So there are several reasons why gastric cancer may become resistant to trastuzumab or other anti-HER2 inhibitors. We should consider the co-amplification of HER3 and EGFR, the heterodimerization specifically with HER3, the presence in about 10% of patients of mutations in HER3 that could also be driving resistance to trastuzumab, and the co-amplification of other factors, for example, c-Met, or even the development of the FGFR autocrine loop. So you know that the family of the HER receptors, EGFR, HER2, HER3, even HER4, to be activated, they need to dimerize, and they may become homodimers or heterodimers. And the point is, when heterodimers of HER2 plus HER3 are formed, those are very potent in stimulating PI3K pathway. So it's a very potent driver of proliferation. So then it is important to try to understand that not all patients are the same, and through different mechanisms of resistance developed, we should act accordingly. It is important sometimes to improve the effect on anti-HER2 drugs that HER3 or even EGFR are completely inhibited. And there are good examples showing that two drugs, the addition of lapatinib to trastuzumab, at least in experimental models, is more active than trastuzumab alone. Even some other anti-EGFR compounds added to trastuzumab may increase anti-tumor activity, again, in very specific tumor models. But also a very big problem is co-amplification. In the upper part of this slide, you may see a case of a patient treated with an anti-c-Met antibody that developed intrinsic resistance because tumor progression was observed immediately thereafter. And this patient had co-amplification of HER2 together with c-Met. So if we think the other way around, many patients with HER2 amplification do co-amplify c-Met, and this could be a very important cause of resistance. And moreover, in this nice study, many patients shared amplification not only of HER2 and c-Met, but also HER1 or even HER3. And in a very nice example in this series of patients treated with anti-c-Met antibodies, patients co-sharing this type of amplification when treated in a combination with trastuzumab and c-Met got nice responses, while other patients treated with single agents developed primary resistance to them. Another important point, and in a recent publication of an Italian group, there is a group of gastric cancer HER2 positive patients, and this is a different phenomenon, non-observed or non-published, as far as I know so far, in breast cancer, is that gastric cancer, when treated with trastuzumab, may develop a specific amplification or a specific microtranslocations or other molecular alterations in FGFR3, and this could be a key point to understand how this, in these patients, HER2 treatments are failing. So as a summary, I would say that it is clear that so far in our populational approach, HER2 amplification has to be determined in all M1 cases. Trastuzumab plus cisplatin-based chemotherapy improves outcomes in HER2 amplified cases. Its role in perioperative or adjuvant therapy is now under investigation. It is clear that gastric cancer behaves differently from breast cancer, and the mechanisms of resistance are diverse and require better understanding. And of course, I see a role for personalized medicine, but rather than launching an arrow to hit a target, I concur with Adam Bass. This is like playing chess, trying to make a strategy to be successful in treating these patients with such a complex disease. On the second part of my talk, I'm going to tackle angiogenesis. And the first thing I would like to make you aware of, that when we are talking about antiangiogenesis, antiangiogenics in gastric cancer, we are only talking about anti-VEGFR or VEGF compounds. And because angiogenesis is a kind of tangled web where there are many participants, many receptors, many cells, many growth factors, and we are only so far tackling one of them. So this is one of the reasons why it is so complex to be successful, and also why we do not have any potent predictors to understand how our patients may improve on this type of therapies. In a setting of second-line therapy, which is very important in gastric cancer, because we have an emerging evidence that second line is important in this disease, with many positive trials comparing best supportive care with chemotherapy. Ramucirumab arrived as a significant active compound, prolonging survival in patients with second-line advanced gastric cancer. So I'm going to address ramucirumab, which is an antibody addressing the receptor, but also another compound, apatinib, which is a TKI that has been also showing some effect in this disease. So the first ramucirumab trial is a huge trial, placebo-controlled trial, in which more than 600 patients progressing after first-line chemotherapy were accrued, and the final result of the trial shows a significant effect on survival, with no effect in anti-tumor activity, but rather delaying a tumor progression, and also affecting quality of life of patients, or said in other words, delaying performance status deterioration in those patients treated with ramucirumab in this trial. But a part of being active as single agent, ramucirumab has been used in combination also in second line with in the association with Paclitaxel in a placebo-controlled trial, again in enormous amount of patients, more than 600 patients randomized to receive weekly Paclitaxel and placebo as control arm versus Paclitaxel and ramucirumab. Again, this is a positive study showing differences in survival for patients treated in the experimental control, but in the experimental arm, but this time there is also increase in anti-tumor activity. So the addition of ramucirumab to Paclitaxel is going to increase responses from 16 to 27%. And also the good point of this approach is that toxicity, and particularly grade 3 and 4 toxicity, is very limited, making this approach feasible in the clinic. The other compound that has been shown to have some activity in second or even third line gastric cancer is apatinib. Is a TKI affecting or inhibiting the vascular endothelial receptor type 2, and it was developed by a Chinese group of investigators in Shanghai, and they showed first data in phase 1 and in phase 2 randomized trial, and a recently published paper showed the results of the phase 3 study, showing a 30% decrease in the risk of death and a prolongation of survival, even in patients with third lines of 1.8 months. This is the design of the study, not so big as the previous ones, comparing apatinib with placebo, and this is the final data of the study showing prolongation of survival in this more heavily pretreated population of patients. So as summary in this part of my talk, I would say that only anti-VEGF or anti-VEGFR therapies has been used as anti-angiogenics. So we have data, I didn't comment on that bevacizumab improves response rate and progression-free survival, but it's not able to prolong survival in metastatic disease. And also, it is not able to improve data on the neoadjuvant setting in increasing the complications, the surgical complications, as we listened to the previous speakers. Ramucirumab prolongs overall survival in second line as single agents, but also in combination with weekly Paclitaxel. And apatinib, an experimental TKI inhibitor, is also prolonging overall survival in patients in second or even third line. And also studies with in early setting of these compounds are on the way. So thank you very much.